think another very exciting, interesting, and intriguing really area for us is the thought of discontinuation of folks who have been on frequently TKI therapy, of being able to stop drug. What are your thoughts on that, Stu?
We are participating in several trials in the United States, and certainly I would encourage, especially the younger patients who are looking at, I don't want to be on a drug for many years, or the older patients with toxicities, to participate off trial. Actually, we are doing it also in our center, following the French model of monthly monitoring. I think the key here is the monitoring of making sure that you have to have a very committed patient who agrees up front that they're going to be monitored. The patient who says, I'm going to stop and then I'm going to disappear, they're danger waiting to happen. But I think this is exciting for a lot of patients.
Do you have a sense of what the percentage of individuals who can stay off drug for a prolonged period of time is?
I think it's changing in my practice, in that the patients who've been on imatinib for a long time, I think a lot of them actually are higher than what the French have been reported, maybe 60, even 70%. But if I look at my entire practice, the patients, it may be lower, because if the patient's only been on drug for a couple years, it may not be as high. So I think the duration that they've been in remission, and actually at this meeting there's several abstracts talking about are the predictors. It's a subgroup of patients, and not all the patients want to discontinue. I think that I'm finding that over half the patients that I approach are saying, it ain't broke, I'm not going to fix it, I'll stay on the drug.
I agree with you. I mean, I have patients coming to the clinic where we can stop therapy, we can put you on these stopping trials. I don't want to take this risk. I'm happy with my TKI. Why you want me to stop therapy? So don't stop, stay on TKI. My concern is, when we look at the data of the monitoring, and you can discover that 15% had never had their PCR done, stopping therapy in the US, and somebody is somewhere, coming to see us in blast phase, because I had a patient coming with a blast phase. Well, disappeared. You try to call them to bring them back to do your PCR testing on a weekly, monthly basis, and they don't show up. And then all of a sudden they are transforming. So I'm very skeptical still, despite the data we have so far, to stop therapy. I need to have clinical trials and be on the trials. That being said, you ask Stu how many patients we can cure and stop therapy. If we do the math simply of patients on TKI, how many can go into CMR or undetectable disease? Around 47, 50%. And then if 40%, 60% will relapse based on a French data, the STEAM trial, then our 20% can be cured and without therapy. The problem is, do we know them? No, we don't. So 80% we know that this will come back, and in the lack of evidence, I'm still skeptical of stopping therapy.
And I'll just say that the studies, I applaud the stopping studies. I think they're fascinating and very interesting and important to do. But there are very few patients that have been on the studies compared to the volumes of patients that are being treated. It's hard not to believe that they're somehow a selected group, whether by motivation issues or just ability to respond so nicely after being on the drugs for a couple of years and having undetectable states. So I do throw that as a caution, that these are 100 patient studies, not 1,000 patient studies.
Yeah, I think this is a really important question for a number of reasons. I agree with Stu. I think anybody who has a patient who's been in a deep molecular response and is potentially eligible for one of these studies, I think they should be encouraged to at least learn about the studies. I agree with Ellie that we don't know with 100% certainty that this is a safe maneuver, but I've been reassured by the data that have been provided. Granted, it's only been from 100 or so patients, but the reason I think this is an especially critical topic is there's actually a presentation at this meeting. Now it's flawed, but there is a presentation at this meeting that is reporting in Swedish patients on imatinib a higher risk of secondary, or a higher rate of secondary malignancies compared with age-matched controls in the same population. But now, of course, we don't know whether it's imatinib or the fact that they are CML patients who are living longer. That's a big caveat. But when we have younger people who have decades of life ahead of them, the potential unknowns of indefinite kinase inhibitor therapy, and including women who wish to become pregnant, women of childbearing age who wish to become pregnant, and then in addition the pharmacoeconomic implications of the stop of treatment studies. I think it's a very it's a very important next step that we need to take. I've actually had, I guess, better success, maybe because on the West Coast people are more likely to just kind of go out on a ledge a little bit. But I've had, in my practice, of the patients that I've approached, I'd say probably 70 to 80% are pretty motivated. I mean, I have people coming from 4 or 5 hours away, despite the fact that they have to come, once a month to get that PCR test for the first year. So I think, yeah, there may be some geographic differences. It may be because I've been talking about the possibility of this study and sort of, informing patients about what's known from the stop of imatinib study, which is, as I said, the French study I've been pretty encouraged by.
Yeah.
And I think these updates from ASH, when presented to our patients, may help encourage them to go on the open studies as well, because some of our patients have been resistant to stop a drug that's working. If it ain't broke, don't fix it.
But you can't be cavalier. They have to be monitored. And if anybody has to be monitored, it's the one who has a potentially salvageable disease that's not on therapy. You have to watch them very, very carefully.
Agreed.
Agreed. That's why it's optimal, I think, to be able to do these in the context of a clinical trial.
Yeah. So Stu, do you have any issues with the monthly monitoring, with getting that paid for the patients? Because that's always a concern I have, is that the guidelines. If I sometimes send a PCR testing more frequently than every 3 months, I'm asked to justify why I'm.
We haven't run into that off clinical trial. I mean, on clinical trial, obviously it's covered, but off clinical trial, we haven't seen problems. And then maybe it's because the insurance companies are realizing, and as we saw at the ASH meetings, you can save millions and millions of dollars to a health system by discontinuing these expensive medications for the cost of the PCRs. But you have to do the PCRs. You have to monitor them.